Hello everyone and welcome to our module on gastrointestinal bleeding. Gastrointestinal bleeding is divided into upper GI bleeding and lower GI bleeding. Upper GI bleeding is bleeding with a source in the GI tract that is proximal to the ligament of Treitz. We'll talk about what the ligament of Treitz is in a minute, but when the bleeding source is proximal to this ligament, blood can get into the stomach, and that leads to hematemesis, which is vomiting of blood. This is often described as coffee ground emesis because that's what bloody emesis can look like. In addition to these findings, patients with an upper GI source of bleeding have blood that can be exposed to stomach acid, and when this happens, the patient can develop melena. Melena refers to dark black, sometimes referred to as tarry black stools. And this is usually a sign of upper GI bleeding from blood being exposed to stomach acid. Rarely, patients with upper GI bleeding can develop hematochezia, which is blood in the stool. Usually this doesn't happen and the patient develops melena, but sometimes there can be blood in the stool. This only occurs when there's a very brisk upper GI bleed such that blood gets all the way down to the rectum without being changed into melena, and therefore you can see frank blood in the stool. More often, hematochezia is a sign of a lower GI source of bleeding. The classic description of a patient with lower GI bleeding is a patient who has bright red blood per rectum. So this is a picture of the duodenum, and the ligament of Treitz suspends the distal duodenum. It attaches to this portion here. So a bleeding source proximal to this will cause symptoms of upper GI bleeding. A bleeding source distal to this will cause symptoms of lower GI bleeding. And here's another drawing just to show you the ligament of Treitz right here. It attaches to the distal duodenum and suspends it to the mesentery. Shown on this slide are some of the common causes of upper GI bleeding. So any process that erodes the mucosa of the upper GI tract can cause upper GI bleeding. So this could be a peptic ulcer, this could be erosive gastritis, it could also be erosive esophagitis. Patients with cirrhosis who develop esophageal or gastric varices can have bleeding from these variceal vessels. And then when patients have portal hypertension from chronic liver disease, the mucosa of the stomach lining can become friable and bleed easily. This is called portal hypertensive gastropathy, another common cause of upper GI bleeding. Some of the common causes of lower GI bleeding are shown on this slide. In the video on colorectal disease, I talk about diverticulosis and angiodysplasia, and both of these conditions can cause lower GI bleeding. Any cause of colitis can cause lower GI bleeding, so this could be ulcerative colitis or ischemic colitis or infectious colitis as well. Malignancies, especially colon cancer, can cause lower GI bleeding. And then lastly, there are many causes of anal bleeding, things like hemorrhoids and fissures. These commonly present as lower GI bleeding. Whether a patient has an upper or a lower GI bleed, there are some general management principles that apply to all patients with GI bleeds. And the first one is that you need to immediately establish intravenous access so that you can administer intravenous fluids or blood products because you don't want the patient to exsanguinate from their GI bleed. So one of the first things that's usually done in patients with GI bleeding is to place 2 large bore peripheral IVs. And large bore IVs are generally 16 gauge or larger. These intravenous devices are capable of transfusing lots of blood or administering lots of IV fluids very quickly. Once you have IV access established in this way, the first thing you do is administer intravenous fluids. And with intravenous fluids alone, many patients will become stable. Some, however, will also need a blood transfusion in addition to fluids. Whether or not you administer a blood transfusion to a GI bleeder is highly individualized to the patient. For patients with severe, very brisk, large volume bleeds, these patients can initially have a normal hematocrit because it takes time for the hematocrit to fall when patients are losing lots of blood volume. So in a patient with a severe GI bleed, you may transfuse that patient even though the hematocrit is normal. For patients with slower bleeds who are stabilized with intravenous fluids, I've listed on this slide some of the commonly used transfusion criteria. For young patients who are relatively low risk for complications, usually a cutoff of 8 milligrams per deciliter for hemoglobin is used. For older patients with comorbidities like diabetes or heart disease, a higher cutoff of 9 is often used. And for patients with variceal bleeds related to liver disease, there was a clinical trial showing that restricting blood transfusions to only patients with a hemoglobin below 7 led to better outcomes, including less rebleeding. The idea here is that when you transfuse blood, you tend to increase the portal pressures, and that can make the varices stretch more and bleed more. So for patients with variceal bleeds, the usual cutoff for transfusion is a hemoglobin of 7. Platelet transfusions are usually restricted to patients with platelet counts less than 50,000. And then for patients who have some form of coagulopathy, fresh frozen plasma or prothrombin complex is sometimes administered. Shown on this slide are some of the blood tests that are usually sent in patients who have GI bleeding. A CBC is usually done. This will measure the hemoglobin and hematocrit. The platelets also need to be measured. Coags are usually sent, including PT, PTT, and INR. And then lastly, you need to send a type and screen so that you can transfuse the patient if necessary. Don't forget about this test. It's actually the most important one because without it, you won't be able to transfuse the patient if you need to. Beyond those general measures, the management becomes different for lower versus upper GI bleeding. Let's talk about the management of lower GI bleeding first. So like we talked about earlier, when patients have hematochezia, that often indicates a lower GI bleeding source. However, it can, in some instances, indicate a very brisk upper GI source. About 10 to 15% of cases of hematochezia are actually due to an upper GI source where the bleeding is so brisk that you get blood in the stool. So in patients with lower GI bleed, one of the things that is usually done is a nasogastric lavage. This is shown on the screen here in this picture. You insert a nasogastric tube, you flush it with fluid, and then you pull the fluid back out and you look for coffee ground material or bright red blood. If either of these findings is apparent after the lavage, that tells you that the hematochezia or the apparent lower GI bleed is actually an upper GI bleed. Once you've done a nasogastric lavage and it's negative for blood, then you know you're dealing with a definite lower GI bleeding source. And so now let's talk about how you manage lower GI bleeds. First of all, for severe, life-threatening lower GI bleeds, the patient needs to go to the OR for surgery to try and identify the source of bleeding and stop it. At the other end of the spectrum, many patients with lower GI bleeds are stabilized with fluids or blood transfusions. The bleeding either stops or becomes very slow. For those patients, they are usually referred for a colonoscopy. Colonoscopy can identify sources of bleeding in the colon, like angiodysplasia or colon cancer. It can also treat many sources of bleeding endoscopically. Colonoscopy is best done after a bowel prep to clean out the colon, so for that reason it's usually done in stable patients in a non-urgent manner. Once the lower GI bleeding has stopped or slowed to a very slow rate, then the patient can do the bowel prep and then have a colonoscopy. For patients with brisk GI bleeds, one option to treat them without surgery is through angiography. Angiography is an interventional radiology procedure where dye is injected into the mesenteric vessels. This is a picture of a mesenteric angiogram shown on the screen here. You can see the black contrast dye filling the mesenteric vessels, and if the patient has a brisk GI bleed, you will see black dye spewing from one of the vessels into an area of the GI tract. Angiography is only useful when the blood loss is in the range of 0.5 to 1 liter per minute, and this is a fairly brisk bleed. And on your surgery rotations, they will want you to know these numbers, so make sure you remember them. The nice thing about angiography is there's no bowel prep needed, and you can intervene to stop the bleeding. So once you identify the vessel that is bleeding into the GI tract, you can inject intraarterial vasopressin, or you can embolize the blood vessel, and either of these techniques will often stop the bleeding. So angiography is usually done in patients with brisk bleeds who you're trying to avoid taking to the OR for surgery. You first see if you can stop the bleeding through angiography. When patients have a slow GI bleed, you can't detect it through angiography. In those patients, they are usually sent for a colonoscopy. But if the colonoscopy is negative and the patient continues to have slow GI blood loss, then there are two tests that can be used to localize the source of bleeding. The first one is called radionuclide imaging. This test involves labeling red blood cells with technetium, which is a radioactive substance, and then you transfuse those red cells into the patient. After that, you can take an image of the patient and areas will turn dark where the red cells are accumulating. And so if you identify a dark area in the GI tract, that can tell you where the source of the slow bleed is. Radionuclide imaging can detect very slow GI bleeds in the range of 0.1 to 0.5 milliliters per minute, and because it can detect such slow GI bleeds, this is the most sensitive test to identify the source of an ongoing lower GI bleed. As an alternative, you can do CT angiography, where intravenous dye is injected and a CT scan is obtained, and you can sometimes see dye accumulating in the GI tract at the source of a lower GI bleed. CT angiography can also detect slow bleeds in the range of 0.3 to 0.5 milliliters per minute. And so as I said, these two tests are generally used when a patient has ongoing bleeding and the source is difficult to identify. After doing one of these tests, you will know where the source of bleeding is and you can come up with a plan to stop it, either through surgery or some other intervention. For lower GI bleeding, there really is no role for medical management. There aren't drugs that we administer to try and stop the bleeding or limit the bleeding. That is not the case for upper GI bleeding. There are some options for medical management. The first one is an intravenous proton pump inhibitor. This is generally given to all patients with upper GI bleeds. because when you cut down the stomach acid, that can sometimes allow the mucosa to heal and the bleeding will stop. And then there are two special medical treatments used only in variceal bleeds in patients with liver disease. Octreotide is a drug used in variceal bleeding that constricts splanchnic arterioles, and this decreases portal flow, so this can limit the bleeding from varices. Antibiotics are also used for medical management in patients with variceal upper GI bleeding. In patients who have cirrhosis and variceal bleeding, up to 20% ultimately develop infections, often spontaneous bacterial peritonitis. So for this reason, antibiotics have been studied and they've been shown to decrease the rate of infections, and they've also been shown to limit rebleeding from varices. Beyond those medical therapies on the last slide, the mainstay of managing upper GI bleeds is with upper endoscopy. This involves inserting an endoscope, which is a camera, into the esophagus. You can visualize the esophagus, the stomach, and parts of the duodenum. This can be done urgently in patients with ongoing GI bleeds who are having heavy hematemesis. They can have an urgent endoscopy. It can often identify the source of bleeding. For example, on the screen is shown a bleeding duodenal ulcer, and then you can treat that bleeding endoscopically. There are a number of techniques to make the bleeding stop. In patients who are stabilized with fluids or blood transfusions, you can also do the upper endoscopy non-urgently to try and see what the source of bleeding may be. Beyond upper endoscopy, there are some other tests that are used in special niche circumstances. You can use angiography to try and identify the source of bleeding in the upper GI tract, just like in the lower GI tract, although this usually isn't necessary because upper endoscopy is often able to treat sources of bleeding. Capsule endoscopy involves swallowing a camera. It passes through the entire GI tract taking images, so this can look for sources of bleeding in upper or lower GI bleeds where you're unable to find a source through other methods. And then lastly, there's a special type of scope called an enteroscope, which can be advanced deep into the small bowel. This is called push enteroscopy. And so in patients who have a negative upper endoscopy, this is sometimes done to try and take images of the small bowel and see if you can identify a source of bleeding that way. I'll finish this video by talking about hemorrhoids, which are a common source of lower GI bleeding. Hemorrhoids are dilated veins that are found in the submucosa of the anus. They can cause bleeding, but they can also cause pain and especially pruritus or itching. They are highly associated with hard stools and straining to defecate. Patients who have difficulty passing stools and strain to defecate often dilate these submucosal veins, producing hemorrhoids. We break hemorrhoids into two subtypes based on their location relative to the pectinate or dentate line. Shown on the screen is a drawing of the anus, and there is a line in the anus called the pectinate or dentate line. This forms because the structures above and below it have different embryologic origins. So when hemorrhoids form above the dentate line, we call those internal hemorrhoids, and when they form below the dentate line, we call those external hemorrhoids. And you can see examples of different types of hemorrhoids in the picture here. This is an internal hemorrhoid above the dentate line. This is an external hemorrhoid below the dentate line. And then sometimes you can have internal hemorrhoids that prolapse all the way outside of the anus. This is a prolapsing internal hemorrhoid shown here. And here's a picture through an anoscope. I just want to point out to you that you can see the dentate line here. It's easy to identify visually with anoscopy, and we'll talk more about anoscopy in a minute. When internal hemorrhoids bleed, the bleeding comes from the internal or superior hemorrhoidal plexus. This is a plexus of veins that is supplied by blood from branches of the inferior mesenteric artery. The venous drainage from this plexus goes to the superior rectal vein and then into the portal system. And so because the plexus of veins associated with internal hemorrhoids drains into the portal system, internal hemorrhoids are much more common in patients with portal hypertension. Those patients have high pressure in the portal venous system, and that can lead to high pressure in this plexus of veins that causes internal hemorrhoids. Above the dentate line, there is visceral innervation but no somatic innervation, so for this reason there is no pain with internal hemorrhoids. The main clinical problem with internal hemorrhoids is that they cause painless bleeding with bowel movements. This is the typical complaint that these patients have. When external hemorrhoids bleed, the bleeding comes from the external or inferior hemorrhoidal plexus. This is a plexus of veins that is supplied by branches of the inferior rectal artery, and the blood from this plexus drains into the inferior vena cava, not the portal vein, so these types of hemorrhoids are less common in patients who have portal hypertension. Usually external hemorrhoids do not bleed. The main problem is that there is somatic innervation below the dentate line. So external hemorrhoids can become very itchy and cause pruritus. Also, they can cause severe pain if they become thrombosed. The diagnosis of hemorrhoids is usually made either by direct examination on rectal exam, or you can use an anoscope, which we talked about earlier. This is a short rigid scope that can be advanced into the anus to identify hemorrhoids. The first-line therapy for patients with hemorrhoids, and it's high yield to know this for your boards, is increased fiber intake. This makes stools easier to pass, so there will be less straining, and this has been shown to improve symptoms and lead to less bleeding and prolapse of hemorrhoids. For patients who have pain or swelling from external hemorrhoids, you can also administer local analgesics or steroids. When patients have refractory hemorrhoids, these patients are often referred to a general surgeon. There are a couple of surgical options to treat them. The first one is rubber band ligation. This is shown on the screen here. It involves placing a rubber band around the hemorrhoid, and then the hemorrhoid will eventually thrombose and fall off. This can only be done for internal hemorrhoids, and it's high yield to remember this. If you do this for an external hemorrhoid, the thrombosed hemorrhoid will become exquisitely painful, and the patient will be very unhappy with you. The other option is surgical hemorrhoidectomy, which is basically surgically excising the hemorrhoid. This is the only option that's available surgically to treat external hemorrhoids because they can't be treated with rubber band ligation. And the last topic for this video we'll discuss is an anal fissure. This is simply a tear in the lining of the anal canal. Shown on the screen is a picture of one. You can appreciate these on physical exam. It's just a tear in the mucosa of the anus. These occur distal to the dentate line, and because of this location, they usually cause anal pain as well as often bleeding into the stool. And the usual cause of an anal fissure is straining to move the bowels in patients who have hard stools. Like I said, the diagnosis is usually made by visualizing the fissure on rectal exam, and the treatment involves a high fiber diet to make stools easier to pass. Local analgesics can be applied to the fissure to take away the pain, and then there are topical versions of the calcium channel blocker nifedipine as well as nitroglycerin. Both of these relax the anal sphincter, and that can make it easier for stools to pass, and then the patient doesn't have to strain so much, and that often allows the fissure to have time to heal. And that concludes our module on gastrointestinal bleeding.